Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, everyone. Thank you for coming today to attend one of the webinar series which have been prepared and initiated, thankfully, by the neuropsychiatry as well as the behavioral neurology group. Special thanks to Dr. Haytham Tayyib and Dr. Abdullah Al-Uzair. So, and I would like to thank the event group, medical event management as well, to get us from all together for today's webinar. I would like to initially invite our esteemed colleague, Dr. Muna Ubaid, who is very well known. She is the director of movement disorder program at King Fahd Medical City. She's also a scientific board member in the Saudi Board of Neurology and several different hats. Today, she is coming as a member of the Saudi Neurology Society. Welcome, Dr. Ubaid.
Okay, thank you, Dr. Najib. Appreciate your introduction. Good evening, everybody. Hope you're safe and well during this difficult time. And thank you as well for attending this webinar today. Dr. Najib introduced me, so I'm going to skip my self-introduction. But today I am representing the Saudi Neurology Society, where I am a board member. So the Saudi Neurology Society was initiated in 2013 and still ongoing and active. It is an honor to be representing this society and endorsing this activity. Today, the webinar is the second in a series of webinars organized by the group of cognitive and behavioral neurology and neuropsychiatry specialists. Cognitive and behavioral neurology is an important field of neurology. The number of specialists in Saudi Arabia is limited. Hence, it's really important that such webinars are conducted because they shed light on this important specialty, and it's going to add significantly to the field of neuroscience, especially in our area. The Saudi Neurology Society aims to raise professional and academic proficiency, enhance excellence in neuroscience, and contribute to improvement of medical care. At the Saudi Neurology Society, we highly value participating in activities that contribute to continuous medical education in the field of neurology and neuroscience in general. Again, I would like to thank the organizers for allowing us, the Saudi Neurology Society, to be part of this educational activity. Special thanks to Dr. Haytham Tayyib and Dr. Abdullah Al-Uzair from the Kuwaiti Psychiatry Group. And special thanks to today's speaker, Dr. Arwa Khalaf, and to our moderator, Dr. Najib Ghadi. As well, I would like to extend our gratitude to the attendees who are attending these activities, and definitely this will be a significant addition to their education and knowledge. I just want to note some society website. Make sure that you register yourself as a member. Currently, the membership is free, and you can do that as well through the Saudi Commission for Health Specialty website. When you become a member of the Saudi Neurology Society, you're going to be notified and updated with all the ongoing educational activities that is endorsed, supported, or sponsored by the Saudi Neurology Society. And thank you again for inviting us.
Thank you very much, Dr. Ubaid. Thank you for your support and the Saudi Neurology Society's support. Now I would like to introduce to you the star of the evening, Dr. Ru'a Khalaf, bright, one of the best cognitive and behavioral neurologists we have in the country at the moment. She's also, she has done her subspecialty in Toronto with one of the Masters of Behavioral Neurology, Professor Friedman. She has also done neurophysiology and movement disorder. Currently, she is the acting chairperson of neurophysiology at King Fahd Specialist Hospital in Dammam. The floor is yours, Dr. Khalaf. Thank you.
Thank you very much, Dr. Najib. I actually have a long list of people to thank tonight. First of all, very special thanks to Dr. Muna Ubaid for joining us tonight. and for the support from the Saudi Neurology Society. Special thanks to Dr. Najib Gadi for joining us in this talk and being part of it. And Dr. Najib is very, again, he's saying that I'm one of the smartest cognitive neurologists and the best cognitive neurologist, but he's actually the leader of cognitive neurology field in the region. And he helped me join this field. He supported me and he played a major role in my journey in cognitive neurology, and I thank him for that. Very special thanks to Dr. Haytham Tayyib, Dr. Abdullah Al-Uzairi, took the courage to start this series. And we're very glad that we're now in episode 2, looking forward to more episodes. And of course, special thanks to Event Troop for their marvelous contribution in the medical education during this tough time in medical education. I will start sharing my slides. And I would like also to thank the Saudi Epilepsy Society, the Kuwait Psychiatry Association for their support. Okay, I'm not sure if you can see the slide. I'll start.
Yes, we can. Go.
Okay. Okay, so
Perfect.
Localization in cognitive neurology. So why localization? Because localization is so unique to neurology. In every field, you take your history, you do your exam, and then you start listing your differential, except in neurology. You have to first localize where your lesion is. Now, in cognitive neurology, well, I look at cognitive neurology as the elephant in the room. We all know it's there, but no one really pays attention to it. And I think in this series, we want to invite this elephant to dinner, and we want to chat and have a talk. We want to introduce everyone to this elephant, cognitive neurology. And I chose to attract everyone by the word localization, because we always miss localization in cognitive neurology. We don't pay a lot of attention. To us, cognitive neurology is dementia, and that's it. But we have to look into the details of that dementia, and if it's really dementia or not, and that's a different talk. And I'll try to, first I have no disclosures. I'll try to cover this in 3 main parts. In part number 1, I'll talk about the cognitive domains, the different cortical cognitive domains. And in part number 2, I'll talk about the bedside assessment, the history taking, and the examination in the clinic. And then I'll try to go over a few cases. I have around 5 cases. I'll try to go over part 1 as quickly as I can, because I assume in future lectures, we'll be talking about cognitive domains in depth and in details. So first, cognitive domains. What are the different cognitive domains that we have? These are the different cognitive domains: memory, executive functioning, attention, working memory, visuospatial function, language, personality and behavior, and praxis. When someone comes to a cognitive neurology clinic, these are the 5 domains that you want to ask about in history, and then you want to test an examination, and then you want to look at in your further testing. I'll try to go over the domains fast, but I'll spend some time with memory, because memory is the most interesting part of it for everyone. So this is HM, Henry Molaison. Henry Molaison contributed to our understanding of memory. Now, he was a patient who had epilepsy, and he had surgical resection of the medial temporal lobe bilaterally. And after the second surgery, he was found to have difficulty retaining new memories. So this is Henry Molaison, assumingly. And after his second surgery, when he was found to be unable to make new memories, his doctor tested him. He was supposed to be drawing, and the idea of this test is to make the drawing hard, the task harder for him. So he is supposed to look at the mirror, and then without looking at the image directly, and then he's supposed, while looking at the reflection of the image, to draw inside the star here. Now, on the first day, this task was explained to him, and then So the task was explained to him, and then he was supposed to do it. As you can see here in the graph, on the first attempt, he made a lot of errors. Then on the second attempt, he made less errors. And the more attempts he had, the less errors he did. On the second day, the doctor came back to him, and she was like, Henry, I would like you to do the task that we did yesterday. And he was like, what task? So he could not remember anything about the task. And despite that, he was able to do the task with less errors, and with more attempts, the errors became much less. And as you can see here on day 3, this was even better, despite the fact that he could not remember at all doing this task before. Now, this was the first time we learned about different types of memory. This was the first time we could understand that memory is not one thing and is not stored in one place. And this was the first time we learned about procedural memory. And why this is important, because when you have a patient with Alzheimer's early on in the course of his disease, even if he has, I would say, significant memory problems, they would still be able to learn new tasks, procedural tasks, and they would still be able to perform learned tasks that they have learned before. And this is important for you in the clinic because you have to decide whether they can still drive, whether they can still go to work, especially if the work is some kind sensitive. Now, these are the different kinds of memory that we usually come across. Episodic memory is the most commonly used kind of memory. And I don't want to say used, but let's say the most commonly known kind of memory to most of the people. So episodic memory is what people usually misname as short-term memory. It's not really short. It's considered kind of a type of long-term memory. So episodic memory is when you remember an event that happened in your life. This event could be last night, could be last week, could be last year. But it's an event, it's an episode of your life. Now, this is what typically affected in medial temporal lobe pathology, typically in Alzheimer's disease. While semantic memory is a different kind of memory, it's more of the memory of things that you know, but you can't really point your finger when and where you learned this piece of information. So the fact that you know that rabbit eats carrot, or the fact that you know King Abdulaziz was the first king of Saudi Arabia, or any historical fact that you know, and you can't really remember when and where you learned this fact, this is where your semantic memory is. And it's usually stored in your anterior pole of the temporal lobe, more lateral. So it's completely different in terms of meaning and in terms of localization than the episodic memory. Procedural memory is what we just mentioned about HM, when he was able to do the procedure despite the fact that he could not even remember seeing this procedure before. And this is where you're driving. If someone, for example, usually does handcrafts or any kind of motor kind of memory, and it's usually stored in the basal ganglia and cerebellum. While working memory, and this is what we call short-term memory, is a completely different kind of memory stored in a completely different location. So working memory is when I give you a few digits and I ask you to rehearse them, and you keep rehearsing them until you dial them, and then they're gone. So this is your working memory. And this is usually stored in the prefrontal cortex. So just to give you an idea, again, I don't want to spend a lot of time on the domains, but I just want you to understand another concept is that, okay, episodic memory is stored in your medial temporal lobe. Now, in order for you to store things in the medial temporal lobe, you need to encode them. So the process of encoding needs your executive functioning, needs your frontal system, needs your subcortical white matter. And then you need your medial temporal lobe to store information. And then you need your subcortical system, again, the prefrontal or the frontal system, again, to retrieve those information. And that's why someone could have memory problem, what looks like memory problem. He could, or no, he does have memory problems, but it's not entirely because he has problems in his episodic memory, and it's not entirely because he has problems in his medial temporal lobe. And that's what I want you to learn today, how to differentiate between problems coming from temporal lobe pathologies and problems coming from frontal, prefrontal kind of pathologies. And we'll go through this in the examination part. So this is PAPE circuit, very important for your episodic memory. I don't want to go through this a lot. Language, again, we know language very well from our stroke rotations. We know we have Broca's cortex, we have Wernicke, and we have the arcuate fasciculus in between. And more or less, it's the same when it comes to neurodegenerative disorders, mostly primary progressive aphasias, the different kinds of primary progressive aphasias. And again, now when most of the pathology is located in the Broca's, it's more of an expressive kind, but it's not as well demarcated as when it comes to stroke. And I think we'll have a separate talk about primary progressive aphasias and how to differentiate them. Executive functions are mostly prefrontal functions, but the overlap between executive functions and prefrontal functions is not complete. So they overlap, but they are not entirely similar. And these are the different prefrontal functions. So energization, task setting, monitoring, behavioral and emotional regulation, metacognition are all functions of the prefrontal lobe. However, task setting and monitoring are mostly executive functions, and these are mostly what we test in the clinic. And we'll go over these tests and how to test them. Before we go to, so the second part is going to be about how to approach these patients in the clinic. So someone comes to you, 65-year-old male patient comes to you, complaining that he's forgetful, or his family brings him complaining that he's forgetful. Now, the first important thing, the first thing that you should ask yourself is, what is it that he forgets? Because forgetful does not necessarily mean that he has typically memory problem. So is it that he forgets word, or is it that he has word finding difficulty? Or does he forget? Word finding difficulty is a very common complaint. I can call it, just like we call sixth nerve a false localizing sign. Word finding difficulty is a false localizing sign in cognitive neurology. You can't really localize anything with this complaint, and you need to dig more in history. But if he forgets appointments, dates, misplaces, objects, here you're talking more about episodic memory. Now, if you forget the meaning of words, so someone who sits on a dining table and you ask him to pass salt and he goes like, what's salt? Now, this person has typically semantic memory kind of problem. So completely different localization, completely different differential, okay? Someone who forgets how to make himself a cup of tea. So you see him, he's a bright person sitting in front of you. He knows what he had for lunch. He knows what where he went last summer, but he just can't figure out how to make a cup of tea for himself. Or he used to be an expert gardener, and now he cannot use the shovel in the garden. So these are all examples of praxis system dysfunction. Okay, so this is the first question that you need to ask yourself and your patient. What is it that he forgets? Now, the second question is to yourself. How true is this problem, and how useful are my tools? You have your tools, and my aim in tonight's lecture is to give you the tools, to give you the hammer and the tuning fork of cognitive neurology so you can figure out what your patient has. But problem is, you have to know exactly how to use these tools. So you have a 65-year-old male patient who has word finding difficulty. He scores 30 out of 30 on MMSE. And you have another patient who's 65, has word finding difficulty, but he scores 25 out of 30 on MMSE. Which one of these two you think has worse cognitive problem, and which one of these two you think may progress into Alzheimer's dementia, or may end up being diagnosed with Alzheimer's dementia? Well, you may say, well, the one who scored 25 out of 30 seems to be more impaired, and you may be right. But reality is, this gentleman who scored 30 out of 30 on MMSE has a PhD in law. He's a retired law professor, and his family noticed that he has major difficulties performing a lot of things that he used to be able to, things like finance, using computer. So although he scored very well on his MMSE, but on history, he does have dysfunction, he does have abnormalities in his ADLs, and not only this, but his premorbid cognitive function is quite high. So someone who has a very highly functioning premorbid condition may find your test very easy. So pay attention to the ceiling effect and floor effect of your tests. Are your tests too easy for your patients? Are your tests too hard for your patients? So this gentleman, the professor in law, ended up being having amnestic MCI in the beginning, and then his MRI showed medial temporal lobe atrophy, his PET scan showed temporal parietal hypometabolism, and he progressed and developed frank dementia, Alzheimer's dementia. While the other gentleman on the other side, who scored 25 out of 30, was sent to the neuropsychological testing, and he was found to have a lot of attentional problems. His wife mentioned that he had a lot of apneic spills at night. He gained 25 kg in the last year, and he ended up being diagnosed with obstructive sleep apnea. He started using a CPAP, and his MMSE improved. So this is just to give you an idea of how these tools can be helpful, but they are not absolute. Now, when you start your bedside cognitive assessment, always look for collateral history. Don't be misled by how your patients look like. You may have a very bright patient who comes to you saying, well, I just started 2 months ago noticing that I'm a little bit forgetful. But then you talk to the family and they're like, we've been suffering for the last 3 years. He's very forgetful. He can't remember anything. So you always need collateral history. And just like any other complaint, you need to know when it started, how it progressed, and whether not there are fluctuations. And I want to focus here a little bit on fluctuations. Why? Because fluctuations are not the simple good and bad days. So every dementia patient would have some good days and bad days. Every family of a dementia patient or any cognitive impairment at any level, if you ask them, does he fluctuate? They would say, well, yes, he does have some good days and bad days. His memory is not always the same, but this is not what we mean with the fluctuation that we point out, that we're trying to point out Lewy body dementia when we talk about them. So the fluctuation here is frank fluctuation in alertness within even 1 day, within few hours. So a person is suddenly very drowsy, doozing, not communicating, and then hours later he's fully awake, fully alert. So that's the kind of fluctuation we mean. Again, duration is very important. And then many neurodegenerative dementias have overlapping impairments, but the chronologic event and the chronologic sequence of events is very important. So yes, most dementias, I can't say that's entirely correct, but most dementias can eventually look the same. But if you go back in history and take detailed history, they never look the same. Always the initial symptom is different. Yes, Alzheimer patient may end up being impulsive and disinhibited, but he cannot start this way. They usually don't start this way. So what questions do you ask? You need to ask about, see the cognitive domains we mentioned earlier in the lecture. You need to go through them in your history, and then you need to go through them in your cognitive assessment. So what questions do you ask? So you ask whether they have difficulty planning and organizing. Now, your patient doesn't have to be a CEO for you to ask whether he has difficulty planning and organizing. Planning and organizing could be as simple as planning and organizing vacation. So they may come to you saying, well, he used to plan all of our vacations. He books the tickets, he arranges the accommodation, but now he's unable to do that anymore. So that's part of planning and organization. Difficulty multitasking, for example, cooking a meal, cooking several meals at the same time. A lady who was perfect doing that before is unable to do that anymore. Poor judgment, making bad decisions. And again, these bad decisions don't have to be major financial decisions. They can be as simple as cleaning something when it spills on the floor. So something spills on the floor, and instead of getting a towel to wipe it off, someone may bring a spoon to scoop it off. So these are poor judgment and bad decisions. Difficulty with problem solving, mental rigidity and inflexibility are all examples of executive dysfunction. Attention and concentration, so things like losing track of thoughts, difficulty following a TV program or a movie, being easily distracted, are all forms of inattention and distractibility. Memory, so memory here we mean episodic memory, so forgetting names, especially of people they just have met. So mostly they can remember their friends' names, their family members' name, but they can't remember names of people they just met and they just knew. Misplacing objects, repeating questions in conversation, that's a very typical example. Rapidly forgetting what he was just told. Using compensatory strategies, and that's very important. You have to understand whether your patient in his pre-morbid condition was using those compensatory strategies, or whether it's a new thing. So there are a lot of people who just keep notes to remember stuff. So it's important to know whether this is a new habit or an old habit. And if it's an old habit, it's important for you to ask whether it's working now. So he probably has been doing this for ages, his whole life, but it's not working now. He forgets where his notes is, or he just can't remember that he wrote some notes and he can go, or he or she can go through these notes. Mixing up dates, forgetting appointments, any evidence, any incidents of leaving the stove or the faucet, stove on or faucet running. Language, again, as I mentioned, word finding difficulty, although listed as a language impairment, but it's not entirely language. It can happen with so many cognitive domain problems. Making speech errors, things like paraphasic, either semantic or phonemic errors. Comprehension deficits, difficulty understanding what he's being told, difficulty understanding instructions, especially when they're complex. Pronunciation and articulation deficits. Loss of word meaning, just like the salt example that we just mentioned. Slurred speech, not making sense when he talks. So fluency problems or reduced speech. Visuospatial and geographic problems, things like trouble navigating. So getting lost in, usually they start by getting lost in unfamiliar places. So if they go to a mall that they haven't been to before, they may get lost, but then eventually they may get lost in familiar places. And even at the end of their disease spectrum, they may get lost within their household. Prosopagnosia, which is trouble recognizing faces, but then he would be able to recognize faces, recognize people by hearing their voices. Trouble finding objects, and that's a very typical example of simultanagnosia, so difficulty finding objects in drawer, in the refrigerator, so whenever a place is crowded. And now I'll go through why this is very important in educating your patient. Trouble parking the car, or driving too close to other cars. Now, personality and behavior, things like disinhibition, changes in social interpersonal conduct, loss of sympathy and empathy. And these are very typical and very frustrating examples in FTD, for example, when they just have no emotional connection to their family. They may be having fun playing, an FTD patient may be playing PlayStation when it's his wife's funeral, for example. So it's very frustrating and it's very remarkable. Changes in eating habits, and again, very typical example of FTD patients, either eating too much sweets or even eating uneatable objects. And we'll come to an example of that. Perseveration, stereotyped, compulsive, ritualistic behavior. So you may have a patient who is compulsively piling things, piling coins, piling toys, any kind of piling or even hoarding. Psychiatric symptoms, so being depressed, having loss of interest. And now it's very important to understand these symptoms because they may be initial symptoms of a neurodegenerative disease. So studies have shown that majority of patients with neurodegenerative disorder had a prodrome of psychiatric symptoms, mostly depression and apathy, loss of interest. But they can be a comorbid symptom. So a lot of people, a lot of dementia patients have comorbid depression. And not only this, but it can be a feature of their disease, just like hallucinations and delusions being part of Lewy body dementia or frontotemporal dementia. Sleep disturbance is important because, as you know, for example, REM sleep behavior disorders are very well known to be associated with synchronopathies, for example. Fluctuation in alertness is a very typical symptom in Lewy body dementia, for example. But not only this, so they can be a prodrome and they can be a precipitating factor for a cognitive problem, things like apneic spills and obstructive sleep apnea, just like the example we mentioned. So people with obstructive sleep apnea can come with cognitive complaints because of their obstructive sleep apnea. So they can be a prodrome, a comorbid, or even a precipitating factor. Gait and balance, and we typically think of them with examples like NPH, and bladder and bowel control. Bladder and bowel control, we need to look at them because they can be a feature like an NPH, and they can be a sequelae. They can happen at the end, and they can affect quality of life for both patients and caregivers. Now, why do we really need to localize in cognitive neurology? If it's dementia at the end, why do we need to know where the problem is? For so many reasons. So reason number one, we need to understand where the location is, because just like any other specialty in neurology, when you know where the localization is, you can start listing differential, because lesions of the medial temporal have differential that are different than lesions of the lateral anterior temporal, prefrontal, occipital cortex, parietal cortex. So the differential is different. I can't say that it's very well demarcated, but there are different differentials depending on the localization. Now, another sequelae of knowing where the location of the problem is how you educate your patient and his family or the caregivers. Because someone who comes to the clinic and his major deficit is memory, that someone who comes to the clinic and his major problem is that he's forgetful, is different than someone who comes and his major problem is visuospatial. The tips that you're going to give for each patient, the psychoeducation and the psycho plan that you're going to make is completely different. And I think we can have a dedicated talk for this. Another thing is, the field in cognitive neurology is jumping. There are big jumps in the field that we probably won't be able to catch up with, and we won't be able to join this train unless we really know what kind of patients we have. I'm not being very optimistic, and I'm not saying that in 5 years from now we will have solution for all neurodegenerative disorders, but I just want to say that 5 or 10 years from now, if they announce that they have a treatment for Alzheimer's patients or for people with dormant prodromal Alzheimer's, which patients are you going to treat if you don't know your patients? And if all patients you have are labeled with dementia, if you don't know who has Alzheimer's pathology and who doesn't, who has FTD pathology and who doesn't, if you don't know your patients, you won't be able to help them and you won't be able to offer them treatment. And another thing that we don't usually pay attention to is clinical trials. There are a lot of clinical trials ongoing that you can advise your patients to join. And if you don't know what your patients have, again, you can't really advise them to go anywhere. So let's go to the cognitive testing, how you can test your patient in the clinic. So before you test the patient, you have to make sure that he has his glasses, if he needs his reading glasses, he has his hearing aids if he's hard of hearing, he had a good night sleep. And if he's taking certain medications, you have to take note of that, because some medications can affect alertness and cognition, like anticholinergic, for example, some sedatives, benzos. So how to test executive function? Let's start with this cognitive domain. So you took history. After taking history, you know based on your history where most of the problems are, and now you can target your cognitive assessment based on your history. Now, this doesn't mean that you should test only the affected cognitive domain by history. You have to test everything, but you can probe the affected cognitive domain or the related cognitive domain further. So the typical testing in executive function is the trail testing. So you have trail A, trail B. Ideally, you should see what number the patient, like how many lines the patient finished and the duration of time. Ideally, you should have norms. Unfortunately, we don't have norms for our population. And I noticed that our population finds it much difficult. Even the educated patients have some difficulty doing the trails. And I feel that we really need to have our own norms for all kinds of testing, and especially for executive functioning and language. So this is an example of executive function testing. Phonemic fluency. So we have phonemic fluency and semantic fluency. Phonemic fluency is when you give the patient a letter and you ask the patient to name all the words he can think of that start with that letter within 1 minute. Typically in English, the letter is F. In Arabic, it's typically حرف الواو, probably حرف الراء, حرف القاف. But these are typically the 3 letters we use in Arabic. The semantic fluency, which is not a test of executive function, it's more a test of temporal function, is when you ask the patient to list a category of, to list words within a category. So animals, for example, the typical example is animals. And you're here testing medial temporal. You're not actually testing for executive function or prefrontal. Another example is the alternating sequence. So either the square triangle or the loops. And I'll show you an example of how this function can look like. And the hand movement, the Luria sequence testing. So fist, then palm, then the side of the hand. He should be able to do it in a certain sequence. And that's, again, another test of executive function. And similarities. So you can ask your patient, for example, how salt and pepper are alike. And he should say that salt and pepper are both spices. But people with difficulties with executive function may go like, they are not similar, they're completely different. And they may keep insisting on this, or they may even find similarities that are not really relevant. Clock drawing is a very important testing. Now, it's typically listed under executive function, but ideally, it's a perfect testing for so many domains. So you can test comprehension, you can test visuospatial, you can test executive function. You can learn a lot about your patient just observing your patient drawing a clock. And there are so many articles and studies and books written on clock drawing. So if I ask you to draw a clock, typically a normal person would go like drawing a circle, a good size circle, and then would go, probably you would start by putting number 12, 3, 6, 9, and then you will start putting the numbers in between. Now, ideally, you say to the patient, I want you to draw a face of a clock. I want you to put in all the numbers and set the hands at 10 after 11. So then the patient would set the hand at 10 after 11. And the trick here is that 10 is 10 minutes, and he should set the hand at number 2 instead of number 10. And here you can see how your patient does. For example, someone who has executive dysfunction, someone who has frontal lobe problems, would probably start drawing a very small circle. And then, because he has difficulty planning, but then he would go like, oh, I need a bigger circle. And he may correct himself and draw a bigger circle. Again, someone who has executive dysfunction may go like, instead of planning where to put the numbers, he may go like putting 12, 1, 2, 3, 4, 5, 6, and then he starts realizing that he's going beyond the numbers, just like here, where the person is perseverating and going beyond number 12. Or they may, and this is a very typical example of a frontal clock, of executive dysfunction clock, he may put the minute hand that is supposed to be a number 2 on number 10, because he's very rigid about his understanding. You said 10 after 11, so he may put the hand at 11 and then at 10. So he did 10 after 11. No abstract thinking, exactly what you said. So And typically, a typical example of hemineglect and visuospatial dysfunction is someone who just ignores half of the circle and just draws on one half. Now, these are all different examples of different dysfunctions when it comes to clock drawing, and I'll show you a clock drawing of someone who has executive dysfunction in the case scenarios. Attention, digit span, serial 7 days of the week. Now, always make sure that if your patient fails on doing the number testing, to do something else that does not have numbers in it. So start with the digit span forward, digit span backward, serial 7s and serial 3s. But then you do days of the week. If your patient does not do the serial 7s and serial 3s, you do the days of the week backward, months of the year backward, because it may be an education problem. He has problems with numbers, or it may be a cognitive problem. He may have acalculia, for example. So you have to know whether it's truly an attention problem. Now, language is typically, again, we usually test language a lot in neurology, so I'm not going to spend a lot of time here, but again, we test repetition. Now, the problem with all of our testing, all of the testing we know, is that we don't have standardized Arabic testing. And this is something that we need to work all together to develop. But in repetition, ideally, you need to start with some small sentences, short sentences, and then you go longer and more complex sentences. Honestly, I don't have typical sentences in Arabic that we can use. I have only one sentence in an Arabic MMSC that I'll show you now. Naming, typically the multilingual naming test, MNT, where you show the patient a picture and you ask the patient to describe what he sees. Now, again, if the patient cannot name what he sees, you can ask him if he knows what we use it for, or you can give him a hint. This again will help you differentiate whether it's really anomia, a naming problem, or agnosia. Reading and writing, typically writing a passage, reading a passage, writing a sentence, reading a passage. Comprehension, where you can ask the patient to perform tasks. Now, you can start with simple tasks, things like midline orders, things like close your eyes, open your mouth. Now, again, those kind of tasks, the midline orders, most of the patients would still be able to do until later on in their disease course. So that's why if they can do this, go to next level, ask them, for example, point to the floor, point to the ceiling. And then if they can do that, you can make it even more complex and say, point to the surface that you walk on. Point to the floor after pointing to the ceiling. So make it more complex, that he needs to understand what you're saying, and then he needs to do multiple orders at the same time. And for language testing, now when we talk about visuospatial testing, I'll show you a test that tests both language and visuospatial, and I love this testing. So visuospatial, you test parietal, occipital, and temporal lobes. So copying a complex figure, things like something like Benson figure. So you ask the patient to copy this. And again, here you're not only testing visuospatial, you can, based on your assessment and observing the patient drawing, you can see whether he has executive dysfunction. Because ideally, a person with a normal executive function would start by drawing the rectangle, then probably the cross in the middle, and then, but some patients would start by drawing the triangle and the flag on the side. And so their planning is not entirely making sense. So observing them drawing can help you enforce and understand more their executive functioning. The cube copy that we typically do with the MoCA is another visuospatial function testing. Judgment of line orientation that you can see here. Identifying overlapping objects. So this is a typical example of testing simultaneognosia. So people with visual cortical problems would have difficulty recognizing the dock, the piano, the screwdriver, and then identifying numbers on Ishihara plate. So although it's a color vision testing, but it's also part of visuospatial function. Describing a complex picture, like the cookie theft picture, and I'll show you the picture now. So again, you can test so many things by just asking the patient to describe the cookie theft picture, which I'll show you now. Asking the patient to reach out for an object, testing for optic ataxia. Typically, we call it a doctor's tie sign. So you will show the patient a pen or something to catch, and then instead of holding the object, the patient would miss the object and probably hold the doctor's tie, and that's why they call it doctor's tie sign. That's a sign or a feature of optic ataxia. Now, the Benson figure, you can test visual memory by asking the patient to draw the figure after a while, typically 10 minutes, from memory, from free recall. Now, this is the cookie theft picture. Now, this is a very beautiful testing for so many domains, again, just like the clock drawing. So you can test language, you can test agnosia. So you can see whether your patient can see the whole picture. So you're testing visuospatial, and then whether your patient has word finding difficulty. So your patient may go like, I say a lady who's cleaning. I don't know what she's cleaning, but you can ask him, what is it? What do we use it for? And he may say, we use it for eating. So he knows it's a plate, but he doesn't know the name, or he can't remember the name. So it's mostly a word finding difficulty. But someone else who has semantic problem may describe something else and may call it something else and may say that we use it for something else. You may have a patient who completely ignore the kids there on the side, trying to reach out for the cookie jar. This is a typical person with visuospatial problem and would completely focus on the lady on the right side, or vice versa. Or you may find a patient who just sees the boy there reaching out for the jar and cannot see anything else. And he's like, oh, it's not clear, I can't see. And this is a typical example of simultanagnosia, where they can't see what's in the picture. So they can't see the details. So again, this is another example of a test that tells you a lot. You can test fluency of the patient, paraphasic errors, if the patient has effortful speech for speech apraxia, for example. So many things, because sometimes it's hard to prompt a patient to talk, to test fluency in the clinic. But if you show them a picture and ask them to describe it, it's probably much easier for them and for you. Memory. So memory is a very interesting part in the testing. And here I want to clarify the points of how to differentiate a medial temporal problem and a frontal problem. So in memory testing, you have two parts. First, you have a task that you have to let your patient learn. And then after a while, you want your patient to recall. So typically, we do the SIRAD verbal list. So you have a list of 10 words that are mostly unrelated. And you either read them out for your patient, or you ask your patient to read them. It can go either way. So you have first trial, typically 1 trial, 2 trials, 3 trials. So trial 1, trial 2, trial 3. So in trial 1, you ask them to read the words, or you read the words for them, and they repeat each word after you. And then you ask them to repeat all the words they can remember immediately. And then you do it again, and then you do it again in a sequence. Now, it's very important here to see the learning curve, to see if the patient is learning with each trial, because this is a good indicator. Now, a person or a patient who cannot remember anything, trial 1, trial 2, trial 3, you can't expect him to remember anything after 10 minutes. Someone who expects him to remember 10 words 10 minutes later. But someone who remembers all 10 words and then cannot remember anything 10. So it's important for you. Can you hear me? It says it's unstable.
Yeah, there's just a little bit of static, but it's fine. Please continue.
It's fine. Okay, thank you. So it's important to look at the learning curve to see whether the patient is learning words with each trial. And then you distract the patient with doing different tasks. And then 10 minutes later, you retest your patient and you say, do you remember the list of words that I told you earlier, or you read earlier? Can you remember, or can you tell me all the words that you can remember from that list? And then you see how many words this person can remember 10 minutes later. And again, it's important to see if they have intrusions. Again, intrusions are more of a sign of a genuine episodic memory problem. So you test them 10 minutes later, and then you see how many words they can remember. Now, if someone can remember, has a good learning curve, and then can remember all 10 words 10 minutes later, they would mostly do well on recognition testing, and you can conclude that they have good memory, or at least they don't have impairment in memory testing. But someone who can't remember, or who remember not enough words after 10 minutes, you should test the recognition and see whether they have problems recognizing the correct words. So in recognition testing, you give them a list of 20 words. 10 of them are correct, they were on the list, and 10 of them are foil, they were not on the list. And you see whether the patient can recognize the correct and the incorrect words correctly. Ideally, most patients, regardless of their age group and their education level, most of them would be able to recognize all 20. They should score 20 out of 20 in this testing. Very rarely we can accept 19 out of 20, but they should score 20 out of 20. Now, what happens here is those people who have genuine medial temporal lobe problem, they have genuine retention problem, they cannot recognize because they simply did not retain any information. So they did not learn, they don't have a good learning curve, they could not recall, their memory is not very well, but then they cannot recognize correctly because the information is not stored in their medial temporal lobe. While those who have good temporal lobe, but abnormal prefrontal cortex, subcortical white matter, so those with vascular dementia, attention problem related to medication, they would be able to recognize the words because the words are there, retained, they just have difficulty retrieving the information. And in this example, or with those kind of people, recognition is typically normal, or at least not as impaired as memory. So different examples of testing that you can do in the clinic. MMSE is a very typical example. Problem with the MMSE is the copyright. Another problem with MMSE is that it does not really test executive function. So it lacks this side, but you can complement MMSE with MoCA. You can test your patients for both. And this can give you a better idea of what your patient impairments are. I love this article, Arabic MMSE. This was done by Dr. Ammar Al-Abedi and his colleagues in Oman. They validated MMSE in Arabic. I use it in my clinic. It's brilliant. They have norms in the article. I advise you to go back to the article. They have norms. They even validated the SIRAD word list in Arabic. So you see here, trial 1, trial 2, trial 3, and then recall, and then recognition testing. And they also have norms for gender, level of education, and age. MoCA is a typical testing. It's very nice because it doesn't have copyright for clinical use. You only need permission if you're going to use it for research. They have an Arabic version. The Arabic version is not validated, but I know Dr. Taimel Maigel in Riyadh is working on validating this, and we're looking forward for his work. He's validating MoCA and MoCA Basic with his group, and this is going to be a very important asset in our cognitive assessment library. So you see here the trails for the executive and visuospatial. So you see the trail, the cube, the clock drawing, which is excellent. Now the clock drawing here, now again, you have to, when you understand the details, you can look into the details and not only the collective mark. So here, for example, this section does not score, it has no score, but for you, it's important to know how many words your patient learned in the first trial, how many words your patient learned in the second trial. And then when your patient scores 0 in the delayed recall, you can relate and you can correlate between the first trial, second trial, and then the free recall. And now you understand how you do that. So this is the MoCA. This is the MoCA Basic, which is mostly for illiterate. You're skipping the parts that need reading and writing or some kind of education. Okay, now let's go to the fun part, clinical scenarios. So the questions that you need to ask in the clinic, you have a patient in the clinic, you have 3 questions that you need to ask. By the end, after your first, or maybe not first, maybe after the second visit, you need to be able to answer all 3 questions. You need to be able to know where your patient's cognitive function is. Does he have subjective cognitive decline, mild memory impairment, mild dementia, moderate, severe? And that's a completely different, separate talk that we can talk about. I find it extremely difficult to find the line between mild cognitive impairment and mild dementia in our population, because most of our elderlies are very taken care of, which is a very good thing. But the downside of that is that most of them, I have a lot of patients in the clinic that when I ask frankly, what is it that he was able to do that he's unable to do now? And they just say, well, he's never done anything. We do everything for him. Kind of like taking care of their mom or dad, but then at the end, you can't really differentiate between MCI and mild dementia. But again, that's a completely separate talk. And then cognitive behavioral syndrome, which is today's talk. So you need to be able to know where the localization of your patient's problem is. Is it medial temporal? So it's amnestic MCI. Is it frontal, prefrontal? So it's dysexecutive, or is it both? Is it primarily language? So is it PPI? Is it primarily visual, visuospatial, PCA, or is it primarily prefrontal, orbitofrontal behavioral variant FTD? And then next question would be, and this 1 and 2, you basically depend on history and cognitive assessment. And then on 3, is it likely a neurodegenerative process or not? So is it Alzheimer's, FTLD, CVD, LBD? And you answer this with your structural and functional MRI imaging, biomarkers, and pathology. And again, this is a separate talk. In today's talk, we're focusing on this second question, cognitive and behavioral syndrome. I'll be going through some clinical scenarios, and I'll show you how, based on history and cognitive assessment, you can tell where your patient's problem is, and I'll show you how we confirm this with testing. So case 1 is a 60-year-old male. He has no chronic medical illnesses, and his problem started 1 year ago with forgetfulness, and it progressed gradually. So forgetfulness progressed gradually. So what is it that he forgets? He misplaces objects, repeats questions in conversations, forgets names and passwords. So you can see here a lot of episodic memory complaints, and that's his initial symptoms. Now, a few months later, he started to have difficulty planning, organizing, making decisions, and multitasking. So now we have some executive dysfunction, but that happened later. It started with episodic memory problems. He may get lost in unfamiliar places, but he's still doing pretty good in familiar places. So he can go to the mosque on his own. He can still drive in the neighborhood, mostly accompanied by his wife. He has some language problems, that is mostly comprehension problems, no behavioral symptoms, and no change in eating habits. And he has insight to his problem. And again, it's important to ask about insight, because in some disorders like FTD, they never have insights, even early on in their course of the disease. But people with Alzheimer's may in the beginning be denying having problems, but then at some point they do have insights to their problem before they start going into moderate to severe dementia. So he needs help in most of his activities of daily living. He does have some comprehension problems, and he does make some wrong decisions. For example, he may dress inappropriately for the weather or for the occasion, but he can still make himself a cup of tea or a sandwich, so his praxis is still fine. He's a retired secretary, high school graduate. He has family history of dementia in his aunts and one cousin. Now, these are the points that I already highlighted when I went through the history. His general neurological exam was normal. He had difficulty following commands, which is, again, very common in cognitively impaired patients. Please don't mix it up with apraxia. So if you have a patient who has moderate to severe dementia, they wouldn't be able to show you how they comb their hair with a comb or how they brush their teeth with a toothbrush. It's not because they have apraxia, it's because their cognitive impairment is quite severe. Well, yes, they may have apraxia, but you can't say at this point that it's abnormality in praxis and, for example, they have CBD. No, it's a progression of their cognitive problem. Now, in cognitive assessment, he scored 16 out of 30, and these are the points that he lost. Now, honestly, and as you will see in another example, someone who scores 16 or 12, like the other lady on testing, you can't really make a lot out of their testing because they would be quite impaired on all domains. But you may have some hints, you may have some idea on what's going on, and you may depend mostly on their history in some cases. Now, on CIRAD word list, he did not remember anything on the first trial. He could remember 3 words on the second trial, but then again, the learning curve is not normal. He remembered only 1 word after the third trial. He was able later on, after 10 minutes, to recall only 1 word. And then he was able to recognize only 17 words. And again, that's abnormal. On CIRAD naming, he was fine, so his naming was fine. His phonemic fluency, he scored 3, semantic fluency scored 6, so both were low. So he's quite impaired in a lot of domains. On the clock drawing, again, he just drew a square and he wrote the word clock inside the square. So you see how advanced his cognitive problem is. But going back to the history, his initial complaint was episodic memory problem and the sequence of events starting with episodic memory, executive dysfunction, and then parietal system with getting lost in unfamiliar places. So this is a very typical example of sequence that happens with Alzheimer's patients. So this is his MRI scan, and you can see how his temporal lobes are quite atrophied bilaterally. And then this is his PET scan, and you can see how he has, so in Alzheimer's, you have temporoparietal, and you can see here his temporal lobes, his parietal lobes bilaterally, showing hypometabolism. And then this is his CSF analysis, because he's young, and in young patients, I always prefer to go further in testing. So his total tau was significantly high, his phosphorylated tau was significantly high, his amyloid was significantly low, and the ratio was significantly low, which is very typical for Alzheimer's. So this patient has Alzheimer's, very typical presentation, very typical finding on testing. The second case is a 72-year-old who has a long-standing history of bipolar disorder. And maybe in the future, when we talk about these kind of dementias, we can point out how psychiatric history is important in those category of patients. Now, his cognitive problems started 10 years ago, prior to his presentation. He is very forgetful, and now that's why his family brought him to the clinic. But his problem started 10 to 15 years ago with spelling mistakes. So he's a businessman, he's very highly educated, but it was very unusual for him to make some spelling errors when writing contracts, for example. And then over time, he started to substitute words. Whenever he finds it difficult to find the correct word, he just substituted it with another word. And then over the last year, he started to just make new words that are completely irrelevant and do not make sense. He became less talkative, and he stopped reading books 5 years ago. Now, he used to be modest and private about his business, but he started to talk openly, sometimes to strangers, about his own business. He could not read facial expressions, and that started like between 5 and 10 years. So he wasn't able to read body language, facial expressions, and this was very difficult for him, and it made it difficult for him to run his own business. So that's very important, reading facial expressions. He was aggressive to his wife. He once slapped a custom officer at the airport. He lost his sense of humor. He may laugh inappropriately. He has a change in his eating habits. He's eating more sweets. He eats lots of ketchup. And on one incident, he drank salt, and on another incident, he put the hand cream in his coffee. So as you can see here, you don't see a lot of memory problems. You see more of behavioral problems, eating uneatable stuff, eating a lot, being inappropriate with strangers. And the language and bipolar history probably in the next episodes, when we talk about FTD and the different variants of FTD, this would make a lot of sense, because people there is an overlap again between PPA and behavioral variant FTD. So again, you can see here that the history has more flavor of behavioral symptoms rather than memory symptoms. And then the memory problem started 4 to 5 years ago, so very late in the course of his disease. Now, okay, now he has no insight into his problem since the beginning. He never had any insight to his problems. His general neurological exam was fine. He was very advanced and impaired in his cognitive function, so he wasn't really able to do much. His comprehension was impaired. He was not fluent. He could repeat single words or short sentences. However, he had difficulty repeating long sentences. So on cognitive testing, he really couldn't do much. This is his MRI scan, and you can see how his anterior temporal lobes are almost gone, with some atrophy in his frontal lobes. So we ended up labeling him with semantic dementia. Unfortunately, we couldn't do PET scan and CSF analysis or genetic testing. Now, this is a 57-year-old female who's known to have diabetes on metformin, dyslipidemia on statins. Okay, I'll try to finish in less than 10 minutes. They noticed a year ago, her family noticed a year ago that she became different. The first thing they noticed is that her reaction time was delayed. She wasn't aware of danger. And then they noticed that she takes longer to think and talk. She's unable to do things that she used to be able to do. Now, notice she's only 57. She misses important steps in cooking. So it's not only that she can't multitask. No, she misses important steps in the cooking sequence. So she may miss putting a very important ingredient. She's unable to type on the phone and now uses voice messages instead. She's unable to switch the TV to the channel she wants. She cannot set the alarm. She cannot use fork and knife to eat. She has difficulty planning and multitasking and makes bad decisions. Now, yes, she does forget names, but that's not really their problems. She basically forget names, but then she's able to remember her daily routine, what she had yesterday for dinner, who came over last week. She may get lost in unfamiliar places. She does not get involved in social conversations. She does not sleep well, no inappropriate behavior, and she did have lost interest in grooming and cleaning. Now, as you can see here, she's unable. The history is telling you that she has difficulty performing things. It's not really a memory problem, although her family wrote her saying that she's forgetful. So again, digging into the history helps you find out what the problem is. Okay, let's skip this. On cognitive testing, she scored 12 out of 30 on MMSE. She lost 10 points in orientation. Now, 12 out of 30, again, like the previous patient, is quite low. And you can't really make a lot out of cognitive testing. You can't really send this patient probably to a neuropsych testing. She wouldn't be able to tolerate. But you can have some hints. For example, on CIRAD word list, she was able to recall 2 words, 4 words, 4 words. So 2, 4, 4. But then she was not able to recall anything. And despite that, she was able to to recognize 10 words of the correct words and 4 words of the foil words. So she scored 16 out of 20. Now that's impaired, okay? That's still not normal. On semantic fluency, she was able to produce 4 words, which is very abnormal. She named only 3 animals in 1 minute. She was unable to describe the cookie theft picture at all. I wasn't able to tell if it was really a language problem, but she was able to give history and give details. So she was not able to recognize the picture. She was not able to describe it, but she was able to recognize faces. So you show them faces of famous people and you see whether they can recognize it, and she could. So it's not a visual problem, okay? So we know in this patient by now, she has a posterior system problem. It's more of a parietal, occipital, but it's probably not occipital because she can recognize faces. She has difficulty understanding proverbs. Naming was impaired. She was unable to copy the pentagon, unable to draw a clock, unable to show on pretend, even on pretend, or on a pantomime, how to brush her teeth, how to brush her teeth, how to use a comb. So she had major difficulties. On testing, on general neurological testing, she was fine. There was no rigidity, no asymmetry. So this is her MRI scan. And you can see here her temporal lobes are quite good. But you can see here posterior system again. So we could tell by history that her problem is definitely posterior system, definitely not temporal lobe problem. And you can see here how her parietal lobes bilaterally atrophied, especially on the left side. Now her PET scan was surprisingly normal, and because Alzheimer's is a great mimicker of everything, we did CSF analysis and it came back normal. She did not have Alzheimer's, but she did have mildly elevated phosphorylated tau protein. So this is a patient in whom we could localize to parietal lobes. We still don't know her diagnosis. She may end up having CBD. She still does not fulfill the full picture of CBD. But you can see how from history, you could tell her problem is not memory problem, is not behavioral problem. Okay, so this is a 53-year-old. He has multiple vascular risk factors, diabetes, hypertension, sorry, that's DM, hypertension, ischemic heart disease. And then 1 month prior to presentation, he was found to be confused, disoriented. It was thought to be a stroke. He was thought, seizures. He was thought to have a stroke. He was started on anti-epileptic drugs. And he improved initially, but then continued to worsen in terms of ADLs. He wasn't focused. He needed help with a lot of ADLs like showering, eating. He was not interested. He forgets phone calls, phone numbers, passwords. He was seen again in the neurology clinic and his anti-epileptic drugs were adjusted and he dramatically improved. So he probably had some subclinical seizures. But despite that, he wasn't yet back to his baseline. On cognitive testing, he did not have any behavioral symptoms. On MMSE, he scored 20 out of 30. I'm not going through the details of his MMSE. I just want to show you features of executive dysfunction on testing. So first, in the memory testing, we gave him 5 words. He was able to register them, but then he was not able to remember any of them 10 minutes later. But then when we gave him options, he was able to recognize 4 out of 5 correct words. So it tells you that it is more of a subcortical problem rather than a genuine temporal problem. Now here you can see the alternating loops. So these first 3 I did, and then these are his loops. You can see his task setting is not correct. He's not exactly drawing the loops. So, but then he was able to monitor. He was able to draw the same thing again and again. Now, with the square triangle sequence, he was just perseverating the loops that he has just done. So you can see frank example of perseveration here. When I asked him to draw the clock, you can see how inattentive he is. He put this number in Arabic and this number in English. I told him to put the hands at 10 after 11, but he just put the hands like this. And when he realized he was probably wrong and he wanted to repeat, he just perseverated the same clock again. Now here, he was trying to write المستشفى التخصصي or مستشفى التخصصي, and you can see how he's perseverating the letters. So التخصصي, he wrote letter ta like 3 or 4 times, and حرف الصاد like twice. Now, a week later, after adjusting his anti-epileptics and his antiplatelets, he did much better on testing. So he's not perseverating as much here. He was able to draw the clock. He felt like he was able to put in the numbers somehow, not exactly correct, but somehow correct. And then when he realized he was probably wrong, he was able to do it again. You can see the perseveration here. So although he's doing much better, but he's still perseverating. He wrote number 2 twice. He wrote number 2 11. So again, you see frank example of frontal subcortical clock. His EEG was normal drowsy. His CSF was non-specific. And these are his images on FLAIR. You can see the white matter changes and the embolic strokes here. So this is an example of vascular kind of dementia. This is my last example. So this is a 60-year-old retired lawyer. He had memory problems for around 3 years prior to presentation. He noticed that he's not as sharp as he used to be. He reads a book, but then he forgets the whole content of the book, which is not very usual for him. He several times left the stove on and the car engine on. This problem started gradually stabilized for a while, and he denies any fluctuation, and he denies any other symptoms. So purely frank episodic memory problems. His mother is 100 years old, has no memory problems. His father passed away at a very young age. He overall reports no family history of neurodegenerative disorders. He used to work as a consultant lawyer and retired 1.5 years ago. So general exam was normal. MMSE was 30 out of 30. MOCA was 23 out of 30. And this is just to show you how you can be misled by one testing and the ceiling effect of the testing. So MMSE was very easy for him. But then MOCA could find out more difficulties and more impairments. He had difficulty with copying the tubes, alternating sequence. So mostly executive function problem. So mostly frontal system problems. His language was normal, attention was normal. He could remember 2 out of 5 words spontaneously and needed cues to remember 2 more. So cues helped, that's more of a frontal, and he could remember the last one when given options. So again, this is a typical example of frontal system subcortical kind of abnormality. He was oriented to place, time, and person. Now, this is his MRI. I'm sorry I missed the temporal cuts, but believe me, the temporal cuts were normal. So his MRI was perfectly normal. He then mentioned on a follow-up visit that his wife reported apneic spells during sleep that he's not aware of. And he reports hypersomnolence and unattended and being sleepy in the very early morning, headache in the early morning, despite good sleep the night before. So he was sent for a sleep study and he was found to have moderate obstructive sleep apnea, and his symptoms actually improved after using the CPAP. So the take-home messages here are, not every memory complaint is a memory problem to start with. And not every memory problem is neurodegenerative in origin. And you can tell this by history and physical examination. Bedside, and mainly cognitive examination. Bedside short cognitive assessments are not always a true reflection of the cognitive status, but they are helpful as methods of objective follow-up. Detailed neuropsych testing is very important and essential in so many cases. Again, in cognitive neurology, just like all fields of medicine, history can help you a lot to find out what your patients have. And again, localization, just like all other subspecialties in neurology. And thank you. I think I went over time.
Thank you very much. Thank you very much. This was really a great presentation. I got to learn a lot. I'm really thankful to you.
Thank you.
So let's, there were a few questions. Let me see. Many people were asking, is this recorded or not? It is not recorded, and is there a certificate or not? Again, I'm not sure. That needs to be asked by the organizers. However, there were 2 questions which I waited for you to kindly tell us. The first one was, you did mention part of it. What Arabic speech and memory standardized tests and tools are handy to have in a neurologist clinic?
So there aren't a lot, honestly. Now, if you want the translated ones, there are so many translated tests, but they're not really validated. You don't have norms. And I think that's the biggest project for all cognitive neurologists in the Gulf now, is to find out, to validate those tests. But Dr. Ammar Al-Ubaidi did a great job with the MMSE, and I put his article. I can show it again. So
I'm not sure if I'm the one frozen or are you frozen? Yes, Dr. Khalaf, I believe you are frozen at the moment.
Internet disconnect.
Okay.
Internet disconnect.
Okay, can you please talk to her so that she can be back with us? So Let me take this question. Regarding, as Dr. Khalaf mentioned, there aren't many. There are few, and most of them are not validated. However, even if they are validated, you do understand that in Arabic, we have different regions have different forms. Like one of the most validated tests have come from Tunisia, and we don't use them. Like for language, they have 4 tests, and their pronunciation is very different from ours, so we are not able to use it. Even MOCA, Montreal Cognitive Assessment, was done in Egypt, and Tim Al-Maigel, Dr. Al-Maigel is working on it here to validate it according to our language. There are other tests. Okay, she's back. Dr. Khalaf is back. Welcome
Sorry.
back, Doc.
I'm sorry.
No, that's fine. I was just trying to fill in for you, but can't do as good as you. So just talking about tests, like one of neurologists, different tests are there. Like for multiple sclerosis, in 2019, Basim Mahmoud's group got the BICAM, which is the International Cognitive International Assessment for Multiple Sclerosis, the MINICTRUM group. But as you mentioned, we haven't many validated tests, and this is where we were. So please, if you continue.
Yes, so Dr. the slide that I show was, I will not try to share screen again so I don't lose connection, but the Dr. Ammar Al-Abaidi in Oman did validate the MMSE, the Arabic MMSE. He translated it and then validated, and they have norms in their article. They also did the SIRAD word list that I showed and the SIRAD naming list. I think that's pretty much it. Some of the psychiatry screening tools, they also translated and validate. And I'm aware that Dr. Taim Al-Maigel in Riyadh is also validating the MOCA and MOCA Basic. I'm not aware of any more, and like we're still waiting for the paper, but I'm not aware of any more tests that are validated. Now, validation is the problem. Dr. Najib, you're mute.
Yes. So maybe ADAS-COG has also come into the picture, but as you said, we don't have many. We need to validate for our region. The other question was, do you know of regional successful examples of ambulatory models of care delivery for memory and speech conditions? Wow, what a question.
I hope we do it. I hope that model exists. I'm sure it might exist somewhere, and this is why we're having these conversations to learn more about our experiences. I just started the multidisciplinary cognitive clinic, so I can't say that I have this model, but I'm not sure if anyone else in the audience has this model.
Does anyone have this model? To some extent, we have it at King Faisal, but not really, not the model which you're talking about, international model. And you have been here for a year or more. I have been here more than a decade. I'm still striving. So hopefully you all would do far better than me.
Yeah, it needs a teamwork. Yes, I agree. It needs it. Yeah. Dr.
Mona Abed had an amazing question. Why don't you ask us, Doc?
Okay, so I did not know how to put the question in Q&A. So my question is, now everybody is using digital monitors like watches, phones to identify time. So how valid is our clock drawing, which I love, and I think it's really important in the near future, because this generation and not even this generation, the generation prior to that are not using the regular clocks. They're using digital numbers. So do you think that's going to affect our tools in assessing cognition in the future?
Yeah, I think it would. It would greatly. Now, until now, I see people are still able to draw clocks, even older people. I can see in 10, 15 years from now, maybe that test would be obsolete and we will need to find something else. And maybe that's another project that we should work on, finding something that is as good as the clock drawing. But yeah.
Okay, I have another question as well related to the clock. How do you instruct them in Arabic on how to draw the clock? Because with different patients coming from different backgrounds, like I work in King Fahad Medical City, so we see patients from different backgrounds, different areas in the kingdom. So when I say ممكن ترسم لي ساعة، okay، في واحد طالع فيه إني كيف ترسمين لي ساعة؟ يعني it does not، ما أعرف أرسم ساعة يد ولا ساعة حائط، ولا مثلا في ناس تقول لهم طب okay face of a clock مرترجمها حرفيا وجه الساعة. It doesn't make sense to some people. And I don't know if you're facing that as well in the clinic. And I tried to get to have a standard way of asking the question, but I would like to know what are the experts' opinion in this. And even like مرة تحط هل تحط مثلا عقارب الساعة حط على هذا الرقم ولا يد الساعة على الرقم الفلاني أو الوقت الفلاني. I'd just like to take your feedback from an Arabic point on how are you instructing your patients, because this might have another reflection on their understanding. Like people may draw a hand and other ممكن يرسموا عقرب. And that's my question.
Dr. Khalaf, are you with us or okay? She has got disconnected again. Okay. Your question was too lengthy. But it was very
how do you say it in Arabic? How do you say it in Arabic?
I agree. It's difficult, and it depends on which area are they from, because different people have different accents, and so it's not that easy. When you tell them, I mean, it's very important, as Ang Lee had put it out of 15. That's why how important clock is. We can score it after 15. But I honestly speaking, 2 years ago, I had a bad and funny moment that I asked my students to draw 10:15, you know, 10:15, and they drew, as you said, digital 10:15. So it's a mess. Dr. Khalaf is back, so we are waiting for you, Doc.
Sorry.
That's fine. The question was, and there are people who are also, their hands are raised. So let's finish with Dr. Ubaid's question, that how do you ask in Arabic, like clock drawing? Because we have different accents, different ways. What do you tell them exactly?
Yeah, so again, yes, I understand that it's hard to really translate the instruction. I usually say, I sometimes need to elaborate more. And although it kind of destroys some part of the testing that you really give details, but I think it still does the job. So what I do is I say, أبغاك ترسم وجه الساعة, but then I say الدائرة, الجزء الدائري من الساعة. Again, this points to الدائرة, so you're kind of giving them a clue. But then if they're really impaired, they wouldn't be able to do it. So and then I say أبغاك تحط كل الأرقام داخل الساعة وبعدين حط الساعة على 11:10. So this is what I say. Most of them, they get it. It's like, again, I just started a year ago, so I can't really say that in my experience, but most of them, they do get it.
No, I'm asking the question because the more I do it, like I notice that I am varying in the way I'm asking the questions.
Yes.
I'm giving someone more hints than the other. Like when I say like draw the circle, like I'm giving a hint, like this, yes. Because I used to examine patients who did not even draw the circle, or who just did a square or a triangle, or put the numbers outside the circle. So, and that's why I ask, because sometimes it's when you don't have it, because we have different accents, to come from different backgrounds, different use of the clock to start with, or the watch. So, and I just wanted
I usually give minimal. I usually give minimal. I just tell them ارسم لي ساعة حائط وحط الوقت, you know, like 10:10 أو 11:10, so that I can score them out of 15. But again, that's variation, and that's why it's very difficult. Dr. Sally, if you will kindly ask us the question. Dr. Sally Muhammad, she is raising her hand. The hand is gone. Dr. Walid.
Thank you so much for this amazing webinar. I really learned a lot, and it's such a great time that we can meet again through this tough times. And thank you for putting this word out, and hopefully this continues to grow. You guys are very rare, and we rely a lot, and we raise on the shoulders of our leaders like Dr. Najib Qadi and everyone else who helped this field grow. So I have actually a couple of comments rather than question. First comment is it's very important to, beside looking at the patient when they're in the room, also outside the room, coming into the clinic, there is so many things that you can learn about their cognitive and behavioral symptoms in that time, how they deal, because sometimes when they come in the room, they act differently. So that's very important. Some clinics I worked in, they actually put a camera and they inform people that they're going to be in a monitored area. So you are observing every single bit of their behavior. The other thing is, sometimes I find it difficult interpreting the MOOCA when it was done by other people. Because you know, the way it is sequenced can mislead you as well. Because you know, when you probe into someone's attention, if they are inattentive, you cannot rely on the rest of the results. Sometimes everything else will be because in the MOOCA you can see that the attention is somehow positioned in the middle of the assessment. So I usually lead by probing into attention first and making sure after that they actually understand and their comprehension is also intact. Because you also, I'm sure from your observation, when people have significant language problems, they usually score like 3 or like 2 out of 30 in the MSc or the MOOCA because they just don't understand, but they still have a lot of other cognitive things. So this is just good points that I usually tell my residents when they rotate with me. So that's one thing. The other thing is, actually, it's a point that speaks into the point raised by Dr. Mona Abeid about adopting the new technology and how actually amazing our brains are in terms of development, like neurodevelopment throughout the, like just us growing as human beings. We sometimes rely on different cognitive domains in different phases of our lives, as well as depending on the, like, what do we have to compensate to, like during, like, for example, a pandemic, you might not need to rely on your memory so much. But for example, for this new generation, we're much more in multitasking and attention and maybe short attention, but like long-term memory is not that great. So we are put in a position where we have to develop our own tools that's actually adaptive of the rapidly growing cognitive demands, as well as things that really speaks into our culture. Like, for example, the picture that you posted, which is very great, that has complex figures intersected together. You have like a picture of a pipe. Honestly, like if you tell me how to translate a pipe in Arabic, I wouldn't know. Like, and maybe I haven't seen one. So these are things that I think Dr. Mona Abeid mentioned, and I think it puts us people who are interested in this field in a position where first we need to validate things that for their norm, and then we have to develop our own tools to keep up with the growing and developing brain of Homo sapiens. Thank you so much for this amazing talk. It's such an informative, well presented, and I really learned a lot, and I actually took some screenshots for my, if you don't mind. So sure. I truly appreciate it. Have a sweet night. Thank you very much.
Thank you, Dr. Walid. Very nice to have you, Dr. Walid. And I can't agree anymore. Yes, we do. Yes, we need to validate available tests, but yes, we need to also invent our own. What do you think, Dr. Najib?
I totally agree with you. Thank you very much for your kind words. And I'm really impressed by the new dynamic people we have now. And I'm sure you people, all of you are far better than me and will do far better work. So I think you have the energy to really validate and think things which go with the society, where, as you're seeing, a lot of changes are there. We are going, our executive functions are developing more and more. I would agree totally with you. It's not as easy. And as Dr. Abeid mentioned, it's not black or white. There are different shades and it's quite different. If you allow me, Dr. Khalaf, there are a few more questions we would like to go through. One of the questions by Dr. Arid Al-Harthi is, what is the role of ginkgo biloba in demented patients? $150 million are spent every year on ginkgo biloba. So what is the
Well,
Does it have any benefit?
I'm not aware of, like, again, coconut oil, ginkgo biloba. I'm not aware of evidence. People say it's, I always tell patients, as long as it's not harmful, as long as you're not taking too much of it, if you feel comfortable doing it, just do it. I don't tell them don't do it. But I'm not aware of evidence. I'm not sure if anyone of the experts with us.
So you're absolutely right. Ginkgo biloba, there was a paper in JAMA 2008. They did a study for 7 years. It came negative. So there's no benefit. As you said, I also tell them if it's okay for you to take it, take it. The only thing in ginkgo biloba is, as you are aware, it causes platelet dysfunction. So if it's an elderly person who has a problem with platelets, I would ask them not to refrain from using it. Coconut oil, they use it a lot. And omega-3 and other aspects, so that's all good. Omega-3 has more evidence. The other question, Doc, was by Dr. Shireen Qureshi, one of our senior esteemed colleagues is here. She's asking the difference between TOCA and MOCA. You know, TOCA, the Toronto Cognitive Assessment Test. Yes, and so TOCA. So what's the difference between them? Which way would you go?
So TORCA, I was trained on TORCA actually.
Wow.
Dr. Morris Friedman, who invented TORCA.
A lot. Yeah.
Yeah, he's the one. So we were using it in the clinic. The difference is there are so many differences. So TORCA is so much lengthy. TORCA, like performing a TORCA on a cognitively normal person would take like 30 to 40 minutes, depending on the experience of the person who's doing the test and how cognitively good or impaired the patient is. It probes domains much more than MOCA. MOCA is just a screening test. TORCA is validated for amnestic MCI. So based on certain equation at the end, you can find the probability of your patient having amnestic MCI. So not only MCI as MOCA, but amnestic MCI. I love TORCA. I was trained on it, but I was trying to also translate it and validate it, but it needs a lot of work. And it's not an easy, like it's not a 5-minute test. It takes a lot of your time. You need a dedicated cognitive clinic. It can't be run in a regular neurology clinic.
This is the problem we had also with CDR. CDR takes a lot of training and a lot of validation. So some tests, yes, they are amazing, but it takes a long time apart from MOCA, which is more of a screening test, helps with amnestic MCI. Dr. Abdullah Uzairi was mentioning that they are also working on many tests, and MMSE and MOCA. For the time constraint, let's go for a few more questions. What about vascular dementia? They're asking, Dr. Tayyib is with us, I believe. So is our time up? Okay.
No,
so,
I was, my hand is raised. So whenever you want to let me talk,
sorry,
if you want to, take that danger, I will be more than honored.
The floor is yours.
Great. Floor is yours. Just a question. It's mentioned here by Dr. Najjar. What about vascular dementia? Usually they present mostly with which cognitive domain? Which cognitive domain is affected in vascular dementia?
So again, it depends on what. Now, vascular dementia is a full topic, is a complete topic. It depends on where the vascular problem is. Is it a strategic site vascular problem, or is it the small vessel white matter changes? Now, typically we say executive dysfunction, generally speaking, we would say, but again, it could be language, it could be memory, if it's a medial temporal. So it depends on the location of the stroke or the lesion, if it's a big stroke, but typically the small silent strokes, it would be subcortical executive dysfunction.
Right. As you said, white matter, frontal subcortical slowing, and other executive function. Dr. Tayyib, the floor is yours.
Oh God! Now, no, I won't be long. First of all, I want to congratulate Dr. Ru'a for her great talk. I really learned a lot. There were so many important points that were made. So thank you so much. And it's also thrilling to hear about all the projects going on in the region, getting things going to get our tools. Dr. Ru'a is working with us in validating the neuropsychiatric inventory, and we have permission to do that from what's his face? I forgot the name. So what do you call this kind of cognitive dysfunction?
Jeffrey Cummings.
Yes,
Jeffrey Cummings did it. Wow,
Yes.
I didn't know that. So we need to work on that because I am about to publish that next month. I didn't
Oh,
know
that's
that.
great. That even better, actually.
Let's work on it
that's
together.
great. That is actually music to our ears, because it means that we can have more than one source of, because as you know, the populations are different in certain aspects. So that's the more the merrier.
But let me send you, because that would really be great, because let me send it to you, and let's work on it together. I mean, I'm sure you are far better in these aspects.
Oh,
so
God,
I would really get to learn from you.
We're better when we're together, and we're very happy for you to take the lead as well. We're also working on growing our homegrown naming test, and we're starting from scratch with the help of people from consultants from Boston, and our own verbal learning test as well. So a lot of activity going on, which is amazing. And I think, but I think, you know, one important point, I know that there's a few trainees in the audience, that, you know, cognitive neurology is beyond just your test tools and beyond your whatever scores you make on these tests. We try to obviously objectify our examinations as much as possible. But I think one important point that many of my junior colleagues sometimes miss is that the cognitive exam is somewhat like your motor exam. You choose which maneuvers to do, which tests to do, depending on what you're suspecting, and you gauge, you know, you guide your examination based on your findings, which I think Dr. Aroa's talk illustrated beautifully. There are different domains. These domains are interdependent. Your tests can tap on more than one different domain, and what tests you do next is dependent on what information you get from the first test. It would be great if the experts in the room tell us how they can parse out, for example, someone comes in and they have difficulty repeating your sentence. How do you know whether this is attention or language, and so on and so forth? Because this is really what the cognitive exam is all about. The people, you know, the junior colleagues sometimes come and say your MOCA test was such and such, or your MMSE cognitive exam shows an MMSE of such and such. And I'm like, that tells me something, but not the whole story. So that's one comment I'd appreciate an elaboration on for the sake of our junior colleagues. The second point, if I may, is about collaboration with our psychiatry colleagues, which I find to be very helpful in selected circumstances. I personally engage frequently in trying to localize our psychiatric and behavioral symptoms. For example, where is this patient's anxiety? Is it predominantly social anxiety, which is known to be in specific involve specific networks? Is this more of a depression, which is known to involve specific networks? And so which hemisphere are we talking about? We know, for example, in mood that the left hemisphere elevates mood, the right hemisphere depresses mood, et cetera, et cetera. So I know that as cognitive neurologists, we engage in this process to a certain extent. But I wonder how often, how good, I know I'm not, I don't think I'm doing a sufficient job in involving my psychiatry colleagues. And I sometimes think that this conversation is extremely important. And vice versa also, how much psychiatry consultations are we getting from our psychiatry colleagues to look for neurological contributions to our presumed psychiatric disorders? So this crosstalk between neurology and psychiatry, what is your experience? What do you think is the direction, and what are your recommendations? I wouldn't sleep if I didn't ask this question. And that's it. Thank you so much.
Thank you.
Thank you. So Dr. Khalaf, you may answer. Of course, Haytham always has the most complicated questions. Amazing. And it's amazing. Yeah, it's a very important and difficult question. Dr. Khalaf, please.
So now I can't remember the questions. Okay.
I'm
sorry.
so sorry.
Sorry.
That's a good start.
So I remember one of them was what to say for the junior colleagues about
Yeah, coming and telling you a score.
Yeah.
And how to, how to parse out which test to, how to guide your cognitive exam without necessarily having to follow number 1 in the MOCA, number 2, number
Yes.
3, and number 4. Yes.
Yes.
So how do you guide your exam?
So for, again, as we mentioned, when we talk about scores, a score of 30 can be, you may end up that I've seen patients who score 30 out of 30 in MMSE, but end up being demented when you send them to neuropsych testing. Like the scores are in the dementia range, and people who score poorly on MMSE or MOCA, but then end up being normal. They just have attention problems. So most of the tests start with attention, like TORCA, like we just talked about TORCA. The first few questions in TORCA, or sorry, tests in TORCA are cognitive, attention testing. Now, when you, as you mentioned, Dr. Haytham, when you have someone who has attentional problems, like the typical example is the delirium patients, you can't go assist delirium patient because he's very inattentive. He won't score on maybe all of your testing. So it's very important to first test the attentive status of your patient. And then it's very important to put everything within the context. So someone who has a repetition abnormality, repetition problem, where in the context of normal all language testing, it's very unlikely for this person, unless he has this conductive kind of aphasia, it's very unlikely for this person to have a neurodegenerative problem affecting language, i.e. PPA, or primary progressive aphasia. But then if you look back, check if your patient has problem with working memory, because maybe he's unable to repeat because his working memory is impaired. So he's unable to rehearse, he's unable to, so working memory is your ability to say things now, to rehearse things and say them now on the spot, which is classically repetition. So again, there is no simple answer for this, but the simple answer would be to put the tests within the context. And at the end, you need to look at what your patient is impaired at, and you try to find a relation between these impairments, because the cognitive assessment a lot of the times is hierarchical. So if one test is affected, it can affect other testing, not because the other domains are affected, but because this test is affected. One of them is language, another one is attention. So yes, that's very important to understand this. Dr. Najib, I don't know if you want to.
I would totally agree with you. It's just that in my humble little experience is that I go a step back. I would rely on the history. And this is where, if I'm able to nail down the history well, I would know really what I'm looking for in the exam. So if a person is delirious, then everything else doesn't matter. And as mentioned earlier perfectly, if a person has difficulty with comprehension or is not able to understand you, so everything else has an issue. Depressed patients, you do understand if a person is depressed, then you have to take, it's a pinch of salt. You have to take, so yes, and then we start with attention, because to rule out delirium, as one of the colleagues here was asking, how do you rule out delirium? So you look for attention tests and you look for serial 7 or the reversal pattern, whatever. So it is difficult. It's not as easy. And that's why after going thoroughly with the history, and if the history and examination are not going in together, then you try to decipher it more, try to ask more until you reach to some kind of ache. And with time, it has humbled me more. When I mean, you guys are brilliant, so you're better. But when I started, I thought that I would diagnose very easily. And time has humbled me that what I know is far less than what I don't know. So it sometimes the idea is wait and watch, because sometimes things evolve and show better. And that's why we usually don't go cross-sectional in cognitive exams or while assessing our patients. We do more on a longitudinal basis. Now, the second question which Dr. Tayyib had was regarding neuropsychiatry. Yes, I agree. They are the other half of the coin, the other side. We really cannot function without them. And to some extent, I was blessed that at King Faisal we had initially Fahad al-Wahabi, who went to King Fahd Medical City later on, and now Mit'ab al-Ataibi. So we do get some benefit, but to be honest with you, each one among us is busy, and unfortunately, our processes are very fragmented. We don't have a clear process where we can come together. That's why I was very much impressed with this initiative, which you, Dr. Tayyib and Dr. Ozairi started, because it's bringing us together. So it's it's like one small step, but a huge leap for mankind. I think this is what we should have done a long time ago. Thank you for taking this initiative. I think we'll get some benefit. I'm not sure if the neuropsychiatrist is here, Dr. Abdullah, or someone who'd like to comment on from their point of view, because their presence is very, very much important for us.
Exactly, I can't agree more.
There was one more question. What is piracetam molecule? This is the last question. What is the piracetam molecule effect on mental status?
I don't have enough experience with it. I've never used it. I've never seen anyone using it. It's not FDA approved for any kind of dementia. So I don't know. I don't know if you have any experience with it or if you've tried it.
Well, from my limited experience, I agree with you. There was just a trial which came in 2019, which caused some hype that piracetam does help. However, if you look at the meta-analysis pool, there is not much benefit in any certain type of dementia. I don't know, Dr. Tayyib, do you have any?
Yeah, I was going to refer to the same data. A related molecule, levetiracetam, and a lot of anti-seizure medicines are actually coming into view right now. And there's a marriage between epileptogenicity and dementia pathogenesis that's been up and coming in the past decade or so, with the idea being that neuronal dysfunction is associated with electrical instability, and that anti-seizure medicines may delay or alter but this is all theoretical at this point. I think there's a few trials with levetiracetam that are small in number, with a lot of caveats. I reviewed them a while back, and I mean that's the only thing I would add.
Great, thank you. Any more questions? I'm just looking at if there are any questions, which I hope I have not missed. And if I have missed, I apologize about that. But yeah, Dr. Rua, it shows how amazing your talk has been, because we are how many hours? 2 hours down, and still 128 participants are there. I have never seen more than 200 participants joining lectures. All my lectures I have given, if I put them all together, they won't reach to 200. So kudos to you. Thank you very much. I'm really honored that I was asked to be a moderator, and I got to learn a lot from all of you. Thank you very much. Thank you, Dr. Tayyib, Dr. Abdullah Al-Ozairi, and Dr. Mona Ubaid, of course. Thank you very much for being
and
there.
I would like to thank, I'd like to thank you. I always had interest in cognitive neurology. This was a very good update to me, and I'm looking forward for your coming the coming episodes. I'll say it's going to be a series that I'll follow. So
thank you very much.
I will definitely want to attend again and again. I'm thankful to the Epilepsy Society for being here. Dr. Raed Al-Barada is here, Dr. Shireen Qurashi. Thank you to them. Thank you everyone who attended, and of course the star of the evening, Dr. Khalaf. Thank you very much.
Thank you, Dr. Najib. Thank you. I'm very humbled by your comments. Thank you. Have a good night, everyone.
Thank you very much.
Thank you, Dr. Haytham. Thanks.
Good night.
Bye.
Thank you.
Good night.
Bye. Bye.